Hi, my name is Isabel Gardet. I am the Director of Industry Engagement for the Cholangiocarcinoma Foundation. I'm happy to welcome you today to today's webinar about a exciting new potential treatment option for cholangiocarcinoma. The webinar today is going to have two parts. We're going to start with a recorded presentation by Dr. Milan Javle from the MD Anderson Cancer Center. And then after that presentation, we're going to have a live Q&A session, and Dr. Javle will be answering questions, and also Dr. Peng from TransThera Biosciences, who's here with us today also. So welcome. If you have questions during the presentation, please feel free to enter them into the Q&A or chat boxes on your screen, or if you're following us on Facebook, go ahead and put your questions in the comment section, and we will be looking at those also. So without further ado, we'll just go over to Dr. Javle.
Okay, I'm going to go ahead and play the video. Give me just a second.
Thank you very much for your kind invitation. My name is Milan Javle. I'm a medical oncologist at MD Anderson Cancer Center, and I'm going to discuss a novel treatment for cholangiocarcinoma with Fgfr genetic alterations, specifically with Fgfr resistance. So the title of this webinar is TT-00420 for Fgfr mutations. So these are a few introductory slides on Fgfr pathway in biliary tract cancer and cholangiocarcinoma. This was one of our earlier papers in 2016, where we looked at over 400 patients and the sequencing data in intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. Intrahepatic cholangiocarcinoma is enriched with a large number of actionable genetic alterations, and 10 to 15% of these patients have Fgfr alterations, most commonly Fgfr fusions, and rarely amplifications or mutations. So this is a cartoon of the Fgfr gene. And like most oncogenes, you have three domains. You have the extracellular domain, you have the transmembrane domain, and the tyrosine kinase intracellular domain, which is shown in its activated form, where it's phosphorylated. So like all oncogenes, it can be mutated, and these mutations can be primary, that is in the setting of no prior Fgfr inhibitors, or acquired, that is mutations that occur as a mechanism of resistance after treatment with prior Fgfr inhibitors. So these mutations have been seen in most commonly in the tyrosine kinase domain, but these mutations can also occur in the transmembrane domain as well as extracellular domain. But by far, the most common Fgfr abnormality seen in cholangiocarcinoma is Fgfr fusion. So this is an interesting paper in 2013 by the University of Michigan group, where they first described that these Fgfr fusions were seen in cholangiocarcinoma. And here they show Fgfr gene that is fused with the BIC1 gene. But there are several other fusions now seen in a variety of other cancers. And in fact, at this time, there are more than 140 fusions described where the Fgfr2 gene is fused with another genetic partner. Now, these fusions form an important target for therapy with specific Fgfr inhibitors or tyrosine kinase inhibitors. So this is a very exciting time for cholangiocarcinoma. Last year, pemigatinib was approved in the setting of intrahepatic cholangiocarcinoma with Fgfr2 fusions or gene and rearrangements who had received prior systemic chemotherapy. This year, the field of cholangiocarcinoma got another shot in the arm with a second approved drug, in this case, infigratinib. Infigratinib was also approved for the same indication, that is cholangiocarcinoma with Fgfr2 fusions or genetic rearrangements after prior systemic chemotherapy, with a response rate of 23% and confirmed and unconfirmed response rate of 34%. So as you can see in this waterfall plot, majority of patients treated with infigratinib experienced some sort of tumor shrinkage or disease control. So that's really exciting. What is sobering, however, is that these responses are not forever. So in fact, in the infigratinib study, the progression-free survival was 7.3 months, and progression is nearly inevitable as time goes on. And this is a similar figure of progression-free survival that you see with most other FGFR inhibitors that are currently being investigated. It is also reflected in the overall survival, where the median overall survival is about a year with infigratinib in patients who have received multiple systemic lines of therapy before. So clearly, we need better drugs to target this situation with FGFR resistance. Now, majority of these acquired resistance is with FGFR inhibitors is because of kinase domain mutations. So there is mutations in the tyrosine kinase domain. So these mutations, FGFR2 mutations that are secondary, are described very well in this figure. The most common one being N549, followed by V564, E565, and a variety of others. These mutations are typically resistant to most FGFR inhibitors. What about primary mutations? That is mutations in the setting of no prior FGFR therapy. As I described earlier, these are quite rare. These occur in about 2 to 3% of cholangiocarcinoma, in case of patients that have received no prior FGFR therapy. And these are data from the FIGHT-202 trial with pemigatinib. So the most common FGFR2 mutation is C382R, and then there's a variety of other mutations that have been described. These mutations, unfortunately, do not respond to most FGFR inhibitors. So patients enrolled with this mutation in the FIGHT-202 trial with pemigatinib, for instance, did not experience any radiological response. So therefore, it's imperative that the next FGFR inhibitors should have efficacy against these primary mutations and hopefully also against the secondary mutations that occur as a result of prior therapy with FGFR inhibitors. So this is where I'm going to describe TT-00420. So this drug is an FGFR inhibitor. It is a strong inhibitor of FGFR 1 to 3, but it also is a multi-targeted tyrosine kinase inhibitor. So it also inhibits VEGFR. It inhibits immune pathways such as JAK-STAT and CSF1R. And it also inhibits Aurora kinase A and B. And these mechanisms are of value because resistance may have different forms. And also perhaps this drug may have activity in a cholangiocarcinoma that does not have FGFR genetic alterations. So in the first series of experiments that were done on this drug, the investigators looked at the activity of TT-00420 against all these FGFR mutations, both primary and acquired. So as you can see, there's a very good activity here with some of these acquired mutations, such as N549, V564, also with E565, which are the more common mutations seen after FGFR therapy. This was also seen in vivo in a mouse model with FGFR BIC1 fusion, along with the resistance N549K mutation, where there's a very good activity seen with TT-00420 with tumor growth inhibition. So therefore, this drug is now being investigated in a human trial. And in the next few slides, I will describe the phase 1 trial results. So this drug has been investigated in over 40 patients now across 7 dose levels. And there are efficacy data available in several of these. Out of 36 patients who had evaluable RECIST measurable tumors, 5 partial responses were noted. The drug has been escalated, as you see, from a dose of 1 milligram to 15 milligram in the phase 1 study. And out of the 8 intrahepatic cholangiocarcinoma treated patients, 2 had experienced partial response. And I'll describe these 2 in the next few slides. Both patients had progressed on 3 prior lines of therapy. These patients had received prior gemcitabine and cisplatin. They had also received prior other FGFR inhibitors and had developed FGFR resistance with other FGFR2 mutations. There were 3 partial responses seen in other tumors, for instance, triple negative breast cancer, HER2 positive breast cancer, as well as prostate cancer. So let us look at first of these patients with cholangiocarcinoma that experienced partial response. This patient is 41 years of age, was diagnosed with intrahepatic cholangiocarcinoma 5 years ago, FGFR2 fusion, typically, and specifically FGFR2, KC, and H7 fusion. This patient had received prior 3 lines of therapy, including gemcitabine, cisplatin, as well as another FGFR inhibitor, and then experienced disease progression. At disease progression, the patient was noted to have the FGFR2 N549K mutation, the acquired mutation. And this patient was then treated with TT-00420. At 2 months, experienced improvement in tumor size by over 22%, and then achieved a partial response, so over 30% improvement in tumor dimensions. Completed 9 months of therapy, and then actually the patient underwent surgical resection and therefore withdrew consent, didn't progress on therapy. And fortunately, even now, over 9 months later, continues to be disease-free. So we hope the disease is cured. These are some of the radiographs here. This is oligometastatic disease. So this is target lesion 1, which you see in the liver here. This improved from 2 to 1.1 centimeter. There's another lesion here, again about 2 centimeters, which improved to 1.5 centimeters. Now let us look at patient number 2, 57-year-old. Now this patient did not have an Fgfr fusion, but actually had an FGFR primary mutation, which is C382R. This patient had received 3 prior lines of therapy, which include gemcitabine cisplatin, gemcitabine Abraxane, and another FGFR inhibitor. This patient was then treated with TT-00420, and at 2 months again had over a 20% improvement in tumor dimensions, and then experienced tumor response, partial response over 30% reduction, and continued treatment for over up to 8 months, and then experienced disease progression. So clearly this is a signal, although these are limited number of patients. Clearly we were encouraged by these findings. These are some of the radiographs on patient number 2, where you see this tumor over 11 centimeters, improved to 7.2 centimeters. This other lesion in the liver, 3.8 to 1.9. And there were also disease in the peritoneum seen, as well as in the peritoneum, as well as in the pelvis. In all of these situations, the tumor did improve for a good duration. Now the question then arises is, what is the safety of the drug? Is it tolerable? So most specific FGFR inhibitors result in a class effect toxicity, which includes hyperphosphatemia, eye toxicity, and nail toxicity. Interestingly, although this drug is potent against FGFR pathway, we don't see these toxicities. There is some hypertension, diarrhea, hand-foot syndrome, or PPE, nausea, vomiting, mucosal inflammation, and proteinuria. Now, most of these toxicities are grade 1 and 2. Grade 4 toxicities did not occur, and significant adverse events were very rare, about 2 to 5%. So overall, while the experience is early, this drug seems to be really well tolerated. Now, the next question arises is, can this drug be used in patients who do not have FGFR genetic alterations? So these are some preclinical data in the lab, and it's important that we look at this because there are few therapies after first-line Gemcis. FOLFOX is commonly used in practice. However, the response to FOLFOX and outcomes are very modest at best. So this drug was investigated against vehicle or TAS-120. Now, TAS-120, like all of the specific FGFR inhibitors, is effective with FGFR altered cholangio. However, it does not have activity against cholangiocarcinoma that does not have FGFR genetic alterations, as you can see here as well. So there was an anti-tumor growth inhibition seen with TT-00420. It was also investigated in combination with chemotherapy. So this is gemcitabine and cisplatin, and the effect seen with gemcitabine and cisplatin. This effect in the blue line shows TT-00420 and the combination in green. So this is a combination again seen with FOLFOX, where you see anti-tumor activity of FOLFOX, anti-tumor activity of TT-00420 in blue, and the combination in green. So there may be some role, perhaps, for combination of this agent along with systemic chemotherapy. So these sort of preclinical data and the encouraging clinical information that we found in trial have led to this ongoing trial, which is phase 2 trial for cholangiocarcinoma with TT-00420. And this drug is being investigated in 3 cohorts. So cohort A will investigate primary and acquired resistance. So in A1, that is patients with cholangiocarcinoma with FGFR2 fusions that have received an FGFR inhibitor but have progressed directly after. They would be enrolled. Cohort A2 are patients with FGFR fusions cholangiocarcinoma that have responded to a prior FGFR inhibitor and then have progressed thereafter, will be enrolled. So I think in these 2 cases, we will be looking at primary resistance and acquired or secondary resistance. Now, we would also look at primary mutations, that is mutations in patients who have received no prior FGFR inhibitors. And these patients will be enrolled in cohort B, as well as other FGFR1 and 3 alterations, for instance, other fusions beside FGFR2. And then there's cohort C, which is FGFR wild type, that is patients who do not have any FGFR genetic alterations. So this, in my view, is an important trial, which will give us some key information in management of FGFR altered cholangiocarcinoma. For more information on this trial, you can look at clinicaltrials.gov, and the NCP trial number is listed here at 049196442. There's also an email listed for if you want any further information on the trial, and this will be available to you through the cholangiocarcinoma group. That concludes my presentation. Thank you very much for your attention. I look forward to answering any questions that you may have related to this drug. Thank you.
Thank you so much. So that was an introduction to the ongoing clinical trial and the science behind this new potential therapy. If you have questions or if you'd like to make a comment, please go ahead and put your questions in the chat box, or if you're following on Facebook, you can put your questions in the comments there. And I'll just go ahead and read out the questions as we get them, and then our panelists can answer. So the panelists, just make sure that you're not on mute, which we were during the video. So I'll just get us started. So this participant says, where would patients who had FGFR fusion initially, but it did not show up later on, fall?
So it's actually quite uncommon to not find these FGFR alterations initially, because FGFR alterations, fusions, are what we describe as truncal events. They occur very early in cholangiocarcinoma, and they persist. They never go away. You get some other mutations in addition, but the fusions are always there. So if you have, but perhaps there's testing issues. It was not detected in an earlier test. It's detected now. So for that, now you have 2 approved options, right? You have pemigatinib, you have infigratinib. This particular trial would be of value if these treatments have stopped working. So they can go for cohort A or cohort B. And they would probably have developed some secondary mutation at that time. But I think there would be first possibility of getting an FDA-approved therapy for that situation that you described.
Thank you. And the other panelists, of course, just jump in if you want to add anything to any of these questions. So the next question we have here is there any exclusion criteria for cirrhosis patients with unresectable disease?
No. So this trial would include patients with unresectable disease. So unresectable disease could mean that they were surgically unresectable for any reason, for instance, cirrhosis of the liver. It doesn't necessarily have to be metastatic for enrollment. So these patients, if they have good liver function, would qualify. Peng or Cindy, if you have any other clarifications, please let us know.
Okay, so in the phase 1 trial, was there any patient without FGFR alteration? And if yes, what was the response rate?
Yes, in the phase 1, for instance, in some of the slides, some of those cases you saw earlier, there were some patients, for instance, with triple negative breast cancer. There was HER2 positive breast cancer, prostate cancer. So some of these 3 patients I'm referring to a larger cohort of a denominator of over 40, they actually experience partial response. So these patients, that's why we are investigating it as well in patients that do not have FGFR fusions, because this drug inhibits other pathways besides FGFR. And so we hope that there will be some activity in these other cholangiocarcinomas as well.
So that means that patients with cholangiocarcinoma who don't have an FGFR alteration are also eligible for the trial?
Yes, they are eligible for one of the cohorts in the trial.
Great. Okay, so and the next question, how long has this been available?
Ben, could you answer that?
The trial is designed in a two-phase. In the first period of recruitment, 6 patients will be screened, evaluated will be screened and recruited. And we have some criteria to evaluate the response. If the response is good, 14 more patients will be enrolled. So totally 20 patients will be enrolled for each arm.
I think the question was, how long has the drug been in clinical trials?
Exactly. So actually, just to add on to what Peng shared, actually initially the first in human trial started by the later 2018. And the first in human trial has been run for about 2 years for now. As you can observe, for some partial responders, they are really stay on the treatment for like 10 more months, even close to a year. So it has been there for quite a while.
Sorry, I'm muting myself. We had a little bit of sound interference there, so just trying to figure that out. But we'll go on to the next question. So is this drug available for compassionate use?
It depends, because for the US, we have the existing sponsor IND. So we would really recommend you to go to the clinical trial, go to the clinical site. But in the country, if there's no existing sponsor IND, sponsors certainly open to consider the compassionate usage.
So it's not open now, Isabel, but I think the goal is to get there.
Okay, all right. But so people who want to access this should go through the clinical trial?
Yes, for now.
Okay. So someone has asked, how often should you be tested? So it sounds like there are maybe alterations that appear later on or following a treatment. So I think that's kind of what the question is about. How often should you get?
So in the ongoing first in human, we really just collect the historical testing result. And in the upcoming new study Dr. Javle just introduced, at the baseline, we also collected the historical report, which in a limited time frame. If the testing is too old, we highly suggest you to redo the testing at the baseline. But if the testing is recently done, we certainly use the recent done test for the qualification or eligibility testing. Along the study in the protocol, what we really suggest is always go along with the clinical kind of event, either the responder or the progressive disease. So that's the time point. It's not going to be really very frequent testing. We are very, conservative and thoughtful on the, patient burden for all these testing.
I'm going to suggest if we are not speaking the panelists, let's mute ourselves because I can't hear very well. I think there's a lot of disturbance. So whoever is not speaking, let's mute ourselves.
Thank you. Yeah. Dr. Javle, speaking of the last question, would you just add, not for this trial necessarily, but do you have an idea in terms of just for patients generally, how often you would recommend that they get tested?
So by tested, you mean like NGS or genetic testing? So certainly, so we don't always now, I'm not referring to the trial, but in practice, when a patient is, say, started on infigratinib or pemigatinib, we rely on a report in time. It does not have to be now. It could be done sometime in the past. As long as they have an FGFR fusion, then they would get enrolled. I generally recommend repeat testing when there's progression, when the drug no longer works. And in this case, if there's reluctance to get a biopsy or the biopsy is not available, we can get a blood test, like a liquid biopsy. I think this is the future, and that's what we should do. So typically, I get asked question in my practice often, if you're on chemotherapy and the chemotherapy doesn't work, should you get a biopsy to look at the genetic profile? And I say no. Generally, the genetic profile is known to change after patients have received targeted therapy, such as TT-00420, pemigatinib, infigratinib, TAS-120, those sort of drugs, not necessarily after chemotherapy. So when you go to a new type of treatment, that's the time to do it, especially after targeted therapy.
Thank you. That's very helpful. Okay, the next question says, there are a few inhibitors that overcome FGFR resistance now, RLY 4008, TAS-120, TT-00420. How do you know which one is the best one to try next?
So, very good question. We don't know. Now, we know from preclinical data that TAS-120 is a very good drug when used in patients who who have not received an FGFR inhibitor before, but actually it does not overcome most of the resistant mutations that were seen in the presentation earlier. We know from preclinical data that 420 does, the relay drug as well. So these are all in trials. So we don't know which one is better. So we just have to go on trials, get more information, and that's how we're going to discover.
So for the WT-FGFR cohort, are there biomarkers that you think would predict resistance to TT-00420? For example, driver mutations such as P53, KRAS, PIK3CA?
So this is a very sophisticated audience. So Peng, in or Cindy, I want to ask you, in your phase 1 study, did you find any markers in the FGFR wild type cohort?
I mean, Peng, maybe you can comment this.
Sure. Because in the first in-human phase 1 study, we didn't collect the genomic data from the patients enrolled. So I don't have a very clear answer for this question, but from our preclinical study, it seems like PI3K mutation might be one of the resistant mechanism in triple negative breast cancer. But we truly don't have very comprehensive data for cholangiocarcinoma yet. So I would say just go ahead and try to enroll in the upcoming trial. And because the genomic data will be collected along the trial, so once we accumulate more data, the answer will become more clear.
Thank you. Yes, that was a very sophisticated question there from the audience. Would you enroll patients based on ctDNA-based test results?
I hope so, but I'm going to leave it to the sponsors, put them in a spot there. Peng and Cindy, if you have a ctDNA with FGFR fusion or with FGFR mutation, would you enroll that patient?
Oh yeah, definitely. The upcoming trial introduced by Dr. Javle in the recorded video is designed by a retrospective analysis method, which means the genomic test is not the inclusion criteria, but we're going to collect the genomic data and the analysis later on. But for the later registration trial, we're going to design the trial in a prospective way to get the genomic data first before the patient is enrolled. And also, we are collaborating with Foundation Medicine the company probably you have already heard of. They have already developed an FDA approved a Ctdna based test with other FDA approved FGFR targeted inhibitors. And we have already entered a collaboration with them for the retrospective as well as a prospective test.
So the answer is yes, Isabel. We will enroll.
Yes.
Thank you. And it sounds like even for the later trial, it's likely that it'll be accepted also.
Yes.
Right.
Okay, do you know what FGFR mutations cause resistance to TT-00420?
So I think this is not known. What mutations, what is the mechanism of resistance to TT-00420? We just completed a phase 1 trial, really. So it's quite early, but we will discover that these patients will get pre and post biopsies and liquid biopsies, and we will see what makes them resistant.
And just one small piece of data for the patient enrolled in the dose escalation for the CCA patients. Peng, you can correct me if I'm wrong, but I remember it's like all patients discontinued before the progress decision. It's like either withdraw consent to because they have been sustainable, stable, or response for long. They just discontinued the withdraw the consent, or they have some other ongoing issue, or kind of discontinued even before evaluable for the response. So at this moment, for the dose escalation population, we do not have one single patient really treated and progressed on the TT-00420 year. So that's the current situation.
Right. So for the two case study reported by Dr. Javle in the video, actually the first one, the patient showed a very good response, and he decided to go on to take the surgery. Yeah, so that's the reason why he stopped the treatment. Actually, it was not due to the drug.
And we have another patient discontinued due to the irrelevant AE first. Actually stopped the treatment due to the irrelevant AE first. 21 days after progressed because of the stop of the TT-00420 treatment.
So I want to point out, not necessarily in relation to this drug, but there are other mechanisms of resistance besides FGFR mutations. For you get other mutations like EGFR, KRAS, NRAS, P53. Those unfortunately are not easy to target with any FGFR inhibitor, but they are much less common than FGFR mutations. But I'm curious, like this questionnaire as well, about what will be the resistance mechanism, and we'll find out.
Thank you. So this question says, I am new to CCA research, so this is a rather basic question. Does kinase inhibitor therapy fall under the heading of immunotherapy, or is this a new type of treatment?
So you're referring to this particular drug, TT-00420. Is it what kind of drug this is?
I would guess so.
Okay. So this is a small molecule tyrosine kinase inhibitor. So this is but it's a multi-target inhibitor. It's a very potent against the FGFR pathway. So FGFR receptors 1 to 3. It also has an immune effect by affecting the JAK-STAT pathway and CSF1R pathway. It has an anti-angiogenic effect by affecting VEGFR. So the belief is, we believe that it affects not just the FGFR pathway, but it affects the entire tumor microenvironment. And therefore, it might have effects on overcoming resistance in other ways, may also perhaps affect non-FGFR related tumors. But it's basically a small molecule, multi-targeted tyrosine kinase inhibitor.
So for now, we are testing the monotherapy of 420 in the upcoming trial. And we do have a collaboration with Roche to combine their anti-PD-L1 antibody with 420, but this trial will be only open in China. However, if the initial results looks very promising, we might also consider to open the similar trial in the States as well.
Great, that's good to hear. So the next question is kind of similar. It says, will this trial open up outside of MD Anderson soon?
Yes, definitely.
Yes.
Cindy, do you want
Yeah.
to give the sites where you're looking at?
Oh, sure. Oh, certainly. We have like a close to 10, which is doing the active site submission at right now. So in addition to MD Anderson, we have a Mayo Clinical, we have a University of Chicago, we have a UNC, and there's also like other long list, Rogers. So actually the trial is posted on the clinicaltrial.gov, and all the clinical sites are listed there. And the interested patient can certainly reach the like a nearby site for the eligibility screening.
That's great to hear that it's going to open up. So how likely is it that FGFR fusion would show up initially in NGS but disappear later? Would it be more likely to get a false negative or false positive for FGFR fusion for extrahepatic cholangiocarcinoma?
So these fusions are almost 98% of the time seen in intrahepatic cholangiocarcinoma. I've seen the very occasional extrahepatic or gallbladder cancer have FGFR fusions. So it's not impossible. FGFR fusions occur in many cancers, in lung cancer, breast cancer, colon cancer. So these can occur. Now, your other question is how often do you see an FGFR fusion come up and it didn't come up earlier? I believe that it's more likely it was a false negative before, because these fusions are almost truncal and they persist throughout. Can the FGFR fusion disappear after treatment? Again, I think more likely a false negative. I've treated a lot of people with FGFR altered cholangio. I've never seen it go away. But I wouldn't say never. It's just probably very rare.
Okay. Please elaborate on the immunomodulatory activity.
Peng, do you want to talk about that?
Sure. So from the target profile, as already introduced by Dr. Javle, in addition to FGFR, 420 also hits VEGFRs along with JAK-STAT pathways. And those two pathways are known for the regulation of tumor microenvironment. And we did test the combination of 420 with a PD-1 in the preclinical model, and indeed additive or synergistic effect were seen. So we believe that the combination with checkpoint inhibitors might be also worth a try in the future.
Okay, and the next question is related. It says, if this drug has an immune effect, does that mean patients less likely to respond to immunotherapy would be less appropriate for this trial?
I don't think so, because in addition to its immune effect, we believe probably in the majority of its anti-tumor activity resulted from its directly targeted effect. And also there has been a lot of publication studies to indicate that a combination with targeted therapy might boost up the immune response as well. So yeah, I don't think it would be less appropriate for this trial if the patient less likely respond to immunotherapy.
Yeah, this drug is primarily against FGFR 1 to 3, and there is an immunomodulatory effect, but I think we have to think of it as really mostly an FGFR inhibitor. And hopefully this immunomodulatory effect will be beneficial, not detrimental to the anti-FGFR efficacy.
Okay. And I know you just answered a question about sites a couple minutes ago, but are you accepting any new clinical trial sites? Yeah.
Yes, we are happy to. So feel free to contact us directly. We are happy to consider new sites.
Great. Is JAK or Aurora inhibition significant for biliary cancers?
So right now,
yeah.
go ahead.
Go ahead, Dr. Javle.
So there is some data with both, with JAK-STAT as well as Aurora K in biliary tract cancer. Most of the data are in the preclinical space, so it's not like the Aurora kinase inhibitors or JAK-STAT inhibitors have been investigated in clinic and shown to have benefit in cholangiocarcinoma. So it's mostly preclinical that there seem to be some effect in models of cholangiocarcinoma.
Right, and also there are some retrospective analysis showing that the expression level of JAK or Aurora might be associated with a prognosis of the biliary cancer patients, but none of the selective JAK or Aurora inhibitors has been demonstrated clinical benefits in the trial yet. But the combination might have some better efficacy, but no clear evidence has been showing that yet.
Thank you. Yeah, so there was a question a little bit ago about potentially getting a false negative for an FGFR. So how can a patient have a negative FGFR result double checked?
So I'll tell you, there was a patient I was corresponding with on email, and there was certain aspects about the patient. The patient was young, had a mutation that was known to be associated with the NFGFR fusion. So we requested that patient to undergo another biopsy. Now we have to remember, no test is 100%, right? There are always some false negative. And it turned out that particular patient actually had an FGFR fusion. These fusions are not common, 10 to 15%. So most of the time when they're not there, they're not there. But there are some clinical features, some associated mutations, which can make the clinician suspicious that perhaps this is a false negative and we should consider again. And that's all I can say. It's an evolving science, and hopefully these false negatives will be eliminated with time.
So would a liver transplant patient taking tacrolimus be excluded from this trial?
At least for the protocol, we don't have this exclusion. And maybe, it's also treating physician decision. So in other words, means it's a Dr. Javle leading trial. So maybe if all investigators believe this should be considered, that is a different situation. But at current, in the protocol, we didn't exclude such a patient.
If you're currently on pemigatinib treatment and the cancer eventually progresses, what determines the next treatment path? Infigratinib followed by TT-00420 or straight to TT-00420? As an engineer, not a physician, I would assume the answer is it depends.
Well, first of all, I hope that doesn't happen, that there's any progression here. But I think a lot depends on the mutational status at progression. Typically, if patient has progressed on pemigatinib directly, I don't think necessarily the patient would respond to infigratinib. Because the spectrum of resistant mutations is relatively similar between these two drugs. If they get N549K or V564, you cannot substitute one versus another because it'll be resistant. So that sort of patient would be basically considered for a clinical trial. Clinical trials such as this or any other such trial that is directed towards these resistant mutations. That would be our preference.
Okay, Allison, do we have any questions from Facebook?
Not any that I've seen. I'll double check though.
Okay. Well, it looks like we have come to the end of the questions here. A really great discussion. I'm glad we had so much time for question and answer after the presentation today. A lot of people really interested in this as a potential for themselves. So thank you so much to our panelists for being here today. Thank you for your presentation, and we will let you know if we hear any more questions.
Thank you. We are here to answer all of them. Bye-bye.
Thanks so
Thank
much.
you.
Thanks so much.
Thank you.
Thank
Bye.
you. Bye.